And the live stream is going to.
Oh, perfect. All right. Ooh, this seems louder today. This is great. Good morning, everyone. Thank you so much for being here early on a Friday. My name is Kristen Moore. I am the current president for the Minnesota Public Health Association. I'm going to start us out by reading our ancestral land statement, which we read at the beginning of every meeting that we do at MPHA. We ask that you take a moment to honor and acknowledge that we are on the ancestral homelands of the Dakota and Anishinaabe. Indigenous people have a long-standing history and connection to land since time immemorial and are the original stewards of lands and waters. Many American Indians were forcibly exiled from their lands because of aggressive and persistent settler colonialism and U.S. governmental policies, but they persevered. We make this acknowledgement to honor the Dakota and Anishinaabe people, ancestors and descendants, as well as the land itself. So I'm going to jump off of here really quick, but first let me introduce you to our moderator today, Ken Bentz. And sorry, give me a second. Ken is the Director of Research Analysis and Policy for the Association of Residential Resources in Minnesota. That is a mouthful, Ken.
Sorry, call it ARM.
Nice, ARM, nice. He is also one of our past presidents of MPHA and one of my great friends here. So, Ken, thank you so much for being here. I'll let you jump in and let's get started.
I didn't get that. Let me try again.
She didn't get it. She did it.
All right, thanks very much, Kristen. Great to see everybody here. Always love doing these MPHA events, and as one of our other illustrious past presidents had said, if it's not fun, it's not public health. So we're going to have some fun today. So as I was looking over the description of this year's Policy Forum series, I really felt that it really encapsulates public health in a nutshell. We're about connecting dots, working outside of silos, thinking outside the box, doing interdisciplinary work to try to solve big topics. And so that's what we're doing today. By coincidence, a couple of weeks ago, I ran across a very helpful article put out by the Center on Budget and Policy Priorities on how to solve homelessness. It says that homelessness, or housing insecurity, is the inevitable result of people's incomes being less than their housing costs. So the very simple solution then is to pass policies that provide resources to people in that situation to supplement their incomes, help them reach the threshold so that no more than 30% of their income goes towards housing. Simple. Simple problem, simple solution, right? So, of course, I'm oversimplifying, but that's essentially what the article says. I'm sure that our panelists will tell us that there is nothing simple about getting such policies passed, whether at the state or at the federal level. The policy work that I do at ARM, to cut down on that mouthful, is in a related area of supporting people with disabilities. And they're one of the segments of the population most at risk for housing instability. So there is some overlap in the works that we do. Going back to this article, it makes some really good points and includes some statistics that illustrate how the problem is getting worse. First of all, the homelessness problem is a choice. Decisions made by policymakers have, if not created it, certainly exacerbated it. In the good old days, and I'm talking between 2007 and 2016, so not all that long ago, federal, state, and local policies contributed to a 15% decline in homelessness. But then came the pandemic, and while housing pressures increased, emergency measures were passed that helped keep homelessness relatively stable. But once that sense of crisis passed, homelessness rose 18% between 2023 and 2024. And so we're not going in the direction that we want to be going. And frankly, this doesn't surprise me, given the inexcusable trajectory of income inequality and the demonization of social support systems. The factors and misfortunes in people's lives are seen as a result of their personal flaws, and they overlook the structural racism and racial inequalities and other flaws in our system and our society. Working on behalf of people with disabilities, I see that we are isolated from that to some extent, which is kind of ironic, because people see that disabilities is not a personal flaw per se. But passing policies that increase investment is still difficult for us too. So as you can see, there's a lot to unpack on this topic, which is why we have selected this panel of 3 subject matter experts to share their perspectives. So let me introduce them briefly so we can get to hear from them. And we'll just go down the line. So to my immediate right is Ben Helvig Anderson. Ben is the Vice President of Policy and Organizing at Beacon Interfaith Housing Collaborative. He helped lead their successful Bring It Home campaign and is currently leading the Supportive Housing Coalition and is co-chair of the Our Future Starts at Home campaign. And full disclosure, my wife worked for Ben at Beacon up until about 6 or 7 months ago, and so I do know something about the work that they do. In the middle is Josh Leopold. Josh is the Senior Advisor for Health, Homelessness, and Housing at the Minnesota Department of Health. He is currently Project Director for a SAMHSA grant to improve housing stability and mental health for people experiencing homelessness. And on the far side is Dr. Kate Diaz-Vickery. Dr. Diaz is a family medicine physician. She serves as Medical Director for Hennepin Care for the Homeless. I remember a lot of the good work that they did from when I worked at Medica. She also co-directs the Health, Homelessness, and Criminal Justice Lab at Hennepin Healthcare Research Institute and is an associate professor in the Department of Medicine at the university. So with that, we're going to get the topic started. So we're going to ask each of them to do about 5 minutes or so on telling about their organizations and what the work that they're doing, and that'll lead us into the next phase and have some conversations. So I'm going to sit down over here. When you see me stand up, that means your time is coming to a close, so just be aware of that. And we'll start with you, Ben. Don't forget this mic going.
Great. Hello, can you hear me now? Yeah. Great. Well, thank you all for being here and appreciate being part of this panel with my colleagues here who are quite experts in their fields as well. So my name is Anderson. I work for Beacon Interfaith Housing Collaborative, and who Beacon is that we are a housing developer and operator of deeply affordable supportive housing. We also are a collaborative of congregations. We work with about 70 faith communities to organize around housing issues for the vision that all people have a home. And so what I'm going to specifically focus on is our particular model and intervention that we do around trying to a piece of solving homelessness in our state, which is around supportive housing. So Beacon is the single largest holder of supportive housing units in the state. We serve about 1,200 residents, 22 buildings, and across specifically in the metro. And what supportive housing is permanent, safe, and affordable homes paired with on-site voluntary services. And so it's for families, individuals, and young people who are at risk or already experiencing homelessness. And so it's not a temporary shelter. We really see it as a home for people to move into and to move forward with their lives. But it's not just a roof over their heads. Residents are met where they're at and offered individual case management, mental and physical health referrals, recovery resources, education and employment support, and more. The services are voluntary and person-centered because we know people thrive when they have agency and choice in shaping their own futures. It also acknowledges all the intersections many residents are navigating around systemic barriers that they or their families or communities have felt, and uses a trauma-informed, culturally responsive approach grounded in the belief that everyone deserves a chance to kind of define their own version of success. And so we really see this housing as health care and health, because supportive housing really is such a low barrier for folks to come in and really have safety and consistency, and really uses the housing first approach that says, right, we need to provide stability for folks, for them to be able to take ownership over how they move forward. And when someone no longer has to worry about where they'll sleep at night, they can finally, schedule doctor's visits, follow a recovery plan, make meals, take their medications, and rest. And we found tremendous success in this model. 86% of our residents move on to long-term housing stability. And just to name a couple examples of the work, because so much of what we try to do is provide housing that really fits the population and fits the individual person and their needs. And so we have youth housing, 3 buildings for folks, for young adults moving out of homelessness, that really individualizes care for them. We've very much been pioneering and driving towards building a lot of family supportive housing, which almost very little exists in the state right now. So we're working on building over 200 units of family supportive housing. 2 buildings are online already and 3 more are coming, which really encompasses a model of having families together and being really moving forward, like a treatment plan or a health plan that's all about the whole family. And one of the key new things we're pioneering there is working with Child Protective Services to actually reunite families in this setting, and to be able for them to have the support to kind of reintegrate and grow back as a family. So often homelessness or addictions or mental health, separates families, and that the healthiest thing for everyone is to come back together and receive the services. We also have buildings that are doing several buildings that are very low barrier, doing trauma-informed housing first model that's harm reduction. So really taking people where they're at, often right out of encampments, and allowing them to kind of find their space to reduce the amount of trauma or the amount of harm that they're doing through maybe an active addiction, and moving them into a recovery in a different way. And so all these models we find are a huge success and really make a difference in the community and supportive housing. But I'll say kind of what Ken mentioned is that just the state of where we're at is quite grim and very difficult. So post-pandemic, we were in very much a growth trajectory of trying to build supportive housing in the state and having a lot of momentum. We have about 7,000 units of supportive housing in the state and need about 15,000 estimated, to really meet the need. But once post-pandemic, as all affordable housing providers saw costs continue to just skyrocket, and the acuity of need in the community and what we receive for those has remained stagnant. And there's also increasing kind of federal threats that I can speak to more about, kind of even threats to the very model itself, and support for that. And so there's a lot of work to be done to kind of while we know this is an incredibly effective model, it needs incredible community support and funding to keep moving forward.
Thanks, Ben. And as you pass the microphone down to Josh, just keep in mind, because we are live streaming, if you keep the microphone as close to your mouth as possible, it'll pick up better. So moving on to Josh.
Okay, is this good? I'm not good at speaking to microphone.
Keep reminding me.
Good. Okay. All right. So my name is Josh Leopold. I work for the Minnesota Department of Health as our subject matter expert on homelessness and housing within the public health department. And so I've been in that position for 3 years. And I would say that during that time, I've seen increasing awareness really across the department about how housing and unstable housing and unsafe housing and homelessness are detrimental to our goals as a health department and our goals of promoting the health of all Minnesotans. And so I think one example of this is one of our responsibilities is to create and regularly update our what's called the statewide health improvement framework. And so over the spring and summer this year or last year, we did a bunch of listening sessions across the state with community about what they saw as their top public health priorities that we should be addressing. And so homelessness and housing instability was one of the top 3 public health priorities that were identified through that process, along with general kind of well-being, which encompasses also mental health and substance use, and then equitable access to healthcare. And so we hear that, when we're in community, but we also hear it, from our grantees, when they talk about, we can't deliver services to people because we can't find them because they're always moving, or when we can deliver services, they don't have a place, their medications get lost or stolen, Or oftentimes also what we hear is, we have pretty robust testing services for people experiencing homelessness. But sometimes, when you're in that kind of day-to-day survival mode of living in unsheltered situations, encampments, getting moved along from place to place, it's kind of like the hierarchy of needs is that they're, getting treatment for an infectious disease, and, especially anything that involves kind of multiple, and Dr. Gregory talk much more eloquently about this, but, anything that involves kind of multiple rounds of treatment, it doesn't work with your life. It doesn't rise to that highest level of priority. So it's a day-to-day thing for us in terms of how we, the intersection between homelessness, housing instability, and public health. And so we know also that homelessness and housing instability are major contributors to the health inequities that we experience in Minnesota. So as a state, Minnesota is 80% white, but most people who experience homelessness are people of color. So for example, about 6% of the statewide population identifies as Black or African American, but 33% of the population experiences homelessness. And similarly, about 1 to 2% of the state identifies as American Indian, but 11% of people experiencing homelessness. So we have these like interlocking systems of, where there's, people of color experience discrimination in the housing market, criminal justice, education, labor force, which all makes them more vulnerable to experiencing homelessness and housing instability, which then contributes to, worsening people's health and reducing their life expectancy. So all this is, pretty well covered ground in terms of diagnosing the problem, but I think it's important, we have to kind of recognize the problem and before we can address it. And I think now we're kind of in that stage of thinking, well, what is public health's role in addressing homelessness and housing instability? And I would say most often, I think when we get involved, where we've been involved is very downstream in terms of how do we do our best to kind of mitigate the health effects of homelessness for people experiencing homelessness. And so, for example, like when I joined the health department, it was in the middle of the COVID pandemic. So a lot of our focus was, before the vaccine, it was on getting PPE into shelters and providing guidance on social distancing and isolation and quarantine. And then when the vaccines became available, it was about, promoting vaccination clinics for people experiencing homelessness. And then once all of the, stuff, all the different misinformation that was going around about what was in the vaccines, once that became dominant, it became much more about, we have a trusted messenger program, so kind of promoting peer level education about, public health based education about what, the science behind the vaccines and the benefits of getting vaccinated. So all of that was like pretty much all encompassing for, 2020, 2021, the first half of 2022. And then in 2022, we partnered with Dr. Victory and her team at Hennepin Healthcare Research Institute to do the first ever statewide homeless mortality study. And sorry, are you up because I'm almost close to my time? Okay,
Yeah.
all right. Didn't catch that the first time. The 5 minutes goes by faster than you think. So anyway, so what we found there was that, people experiencing homelessness were 3 times, their mortality risk was 3 times higher than the general population. Risk of dying from a death related to substance use was 10 times higher. So then we really were focused on overdose prevention and harm reduction for people experiencing homelessness. And now, as thankfully we're starting to see some of those overdose numbers go down, I think we're really focused on, how we can move more upstream and to be a factor in kind of promoting homelessness prevention and tenant rights and removing discrimination against renters. So we can talk more about that in the discussion.
very tough to condense a message into 5 minutes. They go by
I
fast.
was like, how am I gonna fill 5 minutes and then I start talking?
Here we go. All right, thanks, Josh. Moving on.
Thank you. Thank you all for having me. It's an honor to be with you this morning. It's always important. I always appreciate connecting with Minnesota Public Health Association and all of your organizations, but I think it's especially important now as we try to take action and really need to connect the dots for sort of the critical survival of public health, of primary care, and of support for Minnesotans who are experiencing housing instability. I want to start just by acknowledging my lens. So I'm a primary care doctor. I learned research skills. I learned about public health and community engagement because I knew the skills in my exam room weren't enough. I needed more colleagues and partners like you all to teach me and show me those upstream population level impacts that we can take if we partner together. And I think one critical piece to emphasize is that in any of the work I do, I really try to partner with people with lived experience because the solutions I see from my space of privilege are going to be wrong, just systematically. So I need to partner and we need to bring people to the table to think with us about this work and to think with us about the solutions. I have two main recommendations. I'm going to keep it brief because I'm eager to be in more discussion and conversation with you, but I think I'm going to comment most about alignment of housing strategies with health, because I think in spite of all the great work that Ben and Beacon are doing and other housing providers in our state, and in spite of our state health department being among the first to acknowledge homelessness as an important topic area within public health, we have a ways to go. And there has become, unfortunately, a pretty big chasm between public health, healthcare delivery, and housing. And that's because I think these systems and structures are set up to move in different and opposite directions. There's some important connections and important cautions we have to take about respecting people's autonomy and their privacy, but I think we can still work harder at integrating and connecting the dots between healthcare and public health and housing, because sometimes the referrals that Ben's talking about just aren't enough. And in healthcare, we often have a lot of people working in clinics and hospitals who just don't understand the complexities. I do diabetes research, and the American Diabetes Association a few years ago said we should be screening everyone for social determinants of health. We're acknowledging the impact of these social risks on diabetes management. And their solution was to refer people to a social worker so that they can be housed. And that's just comical when you know the complexities of the affordable housing crisis and the many layers of structural barriers that exist across this country to getting housed. And in supportive housing, I see a ton of really great people working at the Healthcare for the Homeless partner housing providers, and I'm sure in Beacon too, who are faced with really challenging overlaps of physical, mental health, and substance use. Really, really challenging environments where the rehabilitation or the long-term care needs of these populations are not being met. And we found in the mortality report that Josh was talking about, these rates of dying 3 times higher mean that a 20-year-old experiencing homelessness has the same rate of death as a 50-year-old in the general population. People are dying sooner of lots of different specific causes, which we can now look at specifically. And that doesn't necessarily get better as soon as they're housed. I want to believe housing is health and healthcare and necessary, but it's a necessary foundation that's not enough. Just when you get housed does not reverse the lifetime accumulation of challenge, of trauma, of risk that faces folks who are still dying early because of those cumulative health effects. So we really need to look at models, in my opinion, biased as I am, of integrating primary care with embedded behavioral health and making those models accessible to folks. And of using folks like community health workers to deliver that support to persist and build trust when people might be reluctant or might be very, have earned distrust of our systems because of how they and their families have been treated in the past. And we need to really get creative about making our spaces promoting good health and lifestyle. So a lot of my research right now is focusing on developing tailored programs to address the health behaviors that we know drive so much of diabetes and its related heart disease and stroke risks, to talk to people about taking their prescribed medications, scheduling and attending their appointments, quitting tobacco, reducing risky substance use. But we need more than just goodwill or general trainings. We need to generate evidence-based models of what this looks like for folks in these settings, which is some of the work we're trying to do in my lab. My second big area that I'd like to see us work more on is to continue to unify and push forward these data systems. We have a lot of goodwill. We have a lot of good aspirations in this state. I think we have a lot of potential to make really important strides, but it's really easy to pat ourselves on the back and focus on the good work we're doing and not measure it. And in the work we did in the mortality report, in this program that my colleague, Dr. Tyler Winkleman and partners built, the Minnesota Electronic Health Record Consortium, we can measure the gaps between COVID vaccination in people who had experienced homelessness using homeless services and the general population. And in spite of a lot of really good work, a lot of good investment in Hennepin County and across the state, the gaps were still huge among the acceptance rate of people to get COVID vaccines. And we're seeing these things persist. We have a project called Health Trends Across Communities, tracking chronic diseases, and another one tracking substance use, hospitalizations, and emergency department visits. And we've added a flag so we can look at users of homeless services in comparison to other groups. These data are starting to exist. They can exist and be built, and we have to be brave enough to hold ourselves accountable to some of these aspirations if we're going to really move the needle and be able to show what we're doing is having the impacts that it really needs to. Thanks.
Simple topic, right? There's many layers to this. Again, this is really public health in a nutshell. How do we help solve this problem? You all did a great job in mentioning the interconnectedness of all the systems here and how health and housing are so inextricably connected. Housing first as an approach, how integrated healthcare, physical health, behavioral health, all those things have to be part of the picture. They're all intertwined, all interconnected. But I want to take a step back from that for a minute. Let's talk a little bit about housing supply. Maybe I'll start with you, Ben, because I know that Beacon does a lot with developing housing and so forth. So where do we stand today in terms of supply? What supply is available? What's considered affordable? And what does the future look like?
Great. Well, I don't have my stat sheet on this, so I'll say some generalities around this, but, and sorry if there we go, I got it. I was speaking too quietly before. So I'll say some generalities about this. I didn't bring the right stat sheet around housing supply issues here, but what we know overall is that there's a huge gap in affordable housing in the state and across the country, and particularly the most acute space of that. And so in the housing world, we talk a lot about AMI, which is area median income, which is a HUD term from the federal government that looks at the incomes of the whole area and finds the median of it, and they study each region. And so what we know is that, and in housing terms, under 50 AMI, housing that's affordable for folks under 50 AMI is seen as affordable. Under 30 AMI is seen as deeply affordable. Well, there's a huge lack of housing overall for everyone, number one. Two, it becomes larger when you're under that 30 to 50 range. And then of course, it's just astronomical when you're down to the 30 AMI range. And there's lots of different reasons for that. And so we just have a huge crisis in supply of housing, and that's all exacerbated right now because of how difficult it is to just operate affordable housing in our environment and how expensive it is. And so most nonprofit affordable housing providers like Beacon are really struggling to expand because we're struggling to just operate and stay afloat with the housing that we have. And so it's a bleak world at this point that needs some big changes in intervention to move forward around our housing crisis.
And on that uplifting note, Josh or Dr. Kate, any thoughts on housing supply?
I guess all I can say about that is I think I encountered pretty quickly in this work the perception that, people are homeless because they want to be homeless or because they're too mentally ill or too kind of far down in their addictions to be in housing. And that is not true. We know from, lots of empirical data that the biggest predictor of how much homelessness there is going to be in a community is the level of affordable housing and that the percent of that housing that's available, so the vacancy rates. And so as housing gets more expensive, the rates of homelessness in that community also go up. And I think, when talking to people, especially I think in the Twin Cities, I think that affordability has been an issue for a long time, and there's been a lot of efforts to address it. But I feel like I'm hearing more for, in smaller cities in greater Minnesota about that they're kind of starting to experience that same issue of, people who might be relying on, Social Security or low wage work where there used to be affordable rental housing, that's all going away. And that's really when you start to see high rates of homelessness.
Ken, I was afraid you were going to ask me questions about things like housing supply, so I crammed because I was a student for a really long time. So I found an article called "What Would It Take to End Homelessness in the United States" in a housing policy journal. Highly recommend this article, and I'm happy to share it with anyone who wants it afterwards. But this article cites some national evidence that says there's a national shortage of 1.5 to 5.5 million units of housing and an additional deficit of 7.3 million rental homes, and then highlights things I think we all somewhat appreciate, but that only 1 in 4 eligible households receives housing assistance from the federal government, which I think just highlights some of the grim statistics that Ben is citing, and definitely more of an expert than I am. And this idea that it's unsolvable is untrue. I think Minnesota has shown what can happen when you make those investments. And I'm very concerned about the conversation at the federal level about scaling that back and rolling that back and prioritizing those savings for, frankly, people who don't need any more savings, in my opinion, and really reversing a lot of the progress we've made.
I think we tend to overemphasize the incidence and the relationship of mental health and how that contributes to homelessness, because it's healthcare overall, and a person may not be homeless because they're mentally ill. They may be mentally ill in addition to other health issues that contribute to their homelessness. I think sometimes it's an easy out to say, oh, it's a mental health issue, and therefore we can ignore some of the other contributing factors that we may be able to help solve. I think that that's important. We're looking at the deficit we have in housing units that seems almost insurmountable. I just observing, you see apartment buildings being built all the time, and so how do we have this persistent shortage in housing units? And as Ben illustrated, we've got different levels of affordability. So we may be building a lot of apartments, but who actually can afford to live there, either with or without supports? Do you have any thoughts from a policy perspective on what should we be advocating for to help more affordable housing be available? Anybody can pick that one up if they want.
Yeah, I mean, I think that there's multiple points to this at this point. I think among the affordable housing industry right now, actually our first is stabilize the affordable housing industry so we don't actually lose more affordable homes. And that is a big point of advocacy that we're actually most focused on right now is about actually not losing homes. I think Minnesota does and has pioneered a lot of great public financing tools to create affordable housing. So much of the deeply affordable supportive housing in Minnesota has been created through housing infrastructure bonds, which is a public financing mechanism that the state can pass via bonds to finance. The federal government does a lot through low-income housing tax credits, and then that's like the secondary area of really building. So of course we need more resources to do that, and then a lot of local governments and agencies also pitch into that. But it's always a piecemeal approach to kind of pull together a whole housing deal and make all the pieces roll together. you're trying to build supportive housing, you need a whole nother layer of trying to get supportive services and funding for that. And then we already mentioned, often for deeply affordable housing, like folks need rent support, you need vouchers some way, and that we have a 1 in 4 folks get federal vouchers. Beacon just worked to pass, and we're part of a coalition that helped pass a new state voucher program that's going to create 5,000 new vouchers. It was like a huge deal, but the amount of people in the state who actually need those vouchers, so we created 5,000. It's about, like 200,000 folks who actually qualify for vouchers in the state who aren't getting them. And so that's just to say that there's enormous need, and while there's a bit of public financing and infrastructure to make more affordable housing happen, we need a lot more of it to actually meet the need.
So I would say, from a public health perspective, we tend to look at things that are kind of broad-based interventions that can reach a lot of people with, a relatively low cost. And so, like, housing is the opposite of that. It's extremely expensive, and it's, as Ben was saying, kind of like unit by unit. But we did we did a consultation with the Network for Public Health Law when we were kind of thinking about where are there interventions where public health could be, instrumental in supporting. And so one of the things that came up was, rent protections for renters. And so what they told us was that, Minnesota actually is one of the top states in terms of renter protections on the books. But we lack kind of the infrastructure to make sure that renters are aware of their rights and can enforce their rights. And so I think that's an area where the health systems and public health, because we are kind of touching people in much more direct ways often than the housing systems, can play a factor. So.
Yeah, I will not add anything as not an expert in this space, except to say that the more I read, the more I am encouraged and hope that we can focus on vouchers and other homeless prevention approaches, because if we cannot build units fast enough to make up this deficit, if we don't stop people from losing the units they're already occupying. So I've been really encouraged by the state's integration of rental support vouchers in schools. I think we should be doing more of that in hospitals and clinics, and that there's a lot of ways we could do more to keep people in the units they have. And, it has to happen on all sides if we're going to make a dent and sort of start reversing these trends.
You've opened up some new threads here. Which direction do I go? So the prevention side is really important. I think we need to think about that. However, I want to pick up what Josh started with this renters' rights versus landlord rights, and where are things going. It's probably best illustrated by what's happening in St. Paul over the past couple of years, and the fight over what's the right balance between helping people stay housed versus landlords' rights to, protect their incomes and protect their properties. I'm not sure what my thoughts are on this, so I'm going to just throw it out there and see what any of you think. So, anybody want to take a stab at that?
I could dive into this, murky waters of kind of rent control or different ways folks talk about it. Just to say that I think that, it's always a balance, and to really look at kind of course, protecting the rights of tenants and making sure, like, there's always bad case scenarios and how to legislate around those of folks dramatically raising rents on vulnerable populations past especially folks on like Social Security or other incomes. It's like, there's always horror stories you hear of that, which is terrible. And then there's the flip side of, like, as an affordable housing provider, right, on many of our buildings, we're already underwater, just trying to keep the building open and working so hard to do that. And so, like an example, even when we have, most of the folks in our buildings, right, have subsidized rent, but then the rent we receive through the subsidy allows us to run the building and provide a quality building. Well, if that's capped and our costs are shooting up, what are we supposed to do? And where does the money come from then to keep the building open? And so I think it is a hard dilemma to really ask. And I don't have, we've advocated for it at some points, and then we've also said, we got to talk about this more with the situation and the exact piece around this, that is that the right intervention? That in the end of the day, very low income housing, deeply affordable housing income does not just work on pure market forces. It was not created because market forces allowed it. We exist only because of public subsidy. And if we're not going to fund it enough to exist like that, it will not exist. And so we cannot just simply look at like one market correction in the private market and say that that's going to be an end all be all, I think. And so it's a much more complex space to operate in.
I don't have a formal opinion about this specific question. I do think it's something we need to be studying and looking at carefully and gathering more data. I think we really want to say housing is health and housing is healthcare and it saves costs, and the actual state of the data is a lot more complex in that space, and how to get there is murky. And I think we've got to try a lot of new things, but also be committed to measuring their impacts, not just in the dollars, but in the health impacts and projecting out what that's going to cost over the lifetime. This article that I read to prepare told me that infants are the most likely to come into homeless shelters in terms of age. And those babies coming home from the hospital into a homeless shelter face a tremendous situation of lifetime adversity if we're not helping to stabilize those families. So thinking about how we think about those costs and investments as a state or as a country, and how we're supporting the full needs of families and people across their life course is essential as we start to try to move ourselves toward understanding costs across all these different buckets that we too often look at in just different fragmented silos.
So I didn't think I had anything to add to this question, but then you said something that sparked my thoughts. But so one of the things that we see is like, to your point about, we know that homelessness is terrible for a person's health, but their health doesn't necessarily, there are some conditions like HIV where I think there's a strong evidence base that once a person gets into housing, you do see improvements in health outcomes. But there's a lot where we don't have that strong of an evidence base. And I think one of the factors is that, people are complex. And so, housing is a necessary but not sufficient factor for their health. And I think sometimes we think like, oh, once a person is in supportive housing, then there are going to be these resources to connect them to healthcare, and maybe then they can get started on medication for opioid use disorder, or start psychiatric medication. But if these housing providers are struggling just to keep the lights on, then it's a lot less likely that intervention is then going to be the thing that gets them connected to all those services. So I think we do need to be, I'm generally kind of like, I think reflexively on the renter side on this topic, but it is important to make sure that the housing provider has the resources to make those service connections.
Great. There are a lot of threads here, and this is the time when you get to speak among yourselves and come up with some questions to feed back to our panel here. So for the next 15 minutes, we're going to have you have your table discussions. You've got on your tables, and so feel free to write questions. They'll be collected. They come back to me, and then I got to pepper these guys with whatever you guys come up with. So the next 15 minutes are yours.
Thank you.
See how fast the time goes.
We have
as always, we've got a bunch of thought-provoking questions, and we may not get to them all, so apologies for that right up front, which means, panelists, your challenge is to try to respond as briefly as possible so we get through as many as we can. We had a couple of questions kind of focused on the impact of sort of age cohorts. What's the status of youth homelessness? What's the status of homelessness in the elderly? We see a lot about youth shelters and their organizations like Youth Link that are there for assisting youths. We have the same amount of support available for elderly who may be experiencing homelessness. So let's start on that thread first. If you just might make sure the microphone is on and we'll get started.
With an acknowledgement that I don't have a clear picture of everything happening across the state necessarily, I think there's been a lot of focus on family and youth homelessness and not enough focus on older adult homelessness and on the complexities and the multiple. I think if we looked at costs, we would see a huge increase in healthcare costs and in the costs of not having a good response for people with complicated health and functional needs later in life. The other big piece that's supported a lot by research by Dr. Margot Cashel out of California is that because of the extreme stress of living in homeless situations and the accumulation of life events that lead you to that point, when I see someone who's 45 in my clinic, they often have the medical complexity and conditions of a 55 or 65-year-old, so that premature aging is a huge factor. And this is where I think we can start to see compounded cost savings if we start shifting the way we're thinking about and measuring some of this. And there's a huge gap and a huge need for more emphasis on senior-specific care. Catholic Charities has a homeless elders program that's very strong and seems always on the brink of not being funded robustly enough to continue. And then there's a huge, we operate a 30-bed medical respite facility, which is excitingly a new Medicaid covered service in Minnesota. However, we get calls every day or every week of older adults or other people with really complex functional needs who cannot independently toilet or get in and out of bed or get down the hall to the bathroom. And we're not able to accept those folks. And I think there's a ton of complex lack of readiness in our transitional care unit rehab facilities and nursing homes for the complexity of the needs of this population. And we really need to be thinking better about those, because if we could create more space and more tailored services, more mental health and substance use readiness in those facilities, we would, I think, be saving, hundreds of millions of dollars in hospital costs and other criminal justice costs and other spaces where these folks are ending up and things are only kind of continuing to spin in chaos and get worse.
Yeah, I would just add that, so we have the Wilder Foundation in St. Paul, and every 3 years they do a very detailed study called, Homelessness in Minnesota, where they go out and survey everybody experiencing homelessness across the state. And
in one night, right?
Yeah, in one night. And then their most recent report, they found that, the group that had the largest increase in homelessness was that, I don't remember offhand exactly what the age cutoff was, but I believe it was like that kind of 50 plus. And so that's definitely a priority area, and a lot of them are experiencing homelessness for the first time in their lives at an older age. So they're kind of unfamiliar with, how the system works and what benefits are available. And then there are a lot of the, homeless shelters were designed with the needs of older adults in mind. And so, as Kate was saying, they kind of lack both the services, but also just the accessibility. Like if you're in a wheelchair or if you have mobility challenges, that really limits your shelter options. So it's a big need.
I'll let that answer it.
All right, I know in my second job, I said my policy work is in the public safety sphere, and I see a lot of people remaining in their homes probably longer than they should have as they're aging. So we run into a lot of situations where we call heavy contents, otherwise known as hoarding, where it's very difficult even to maneuver through a person's home. They've accumulated stuff for years, are not as mobile, so they can't weed things out like they used to, so things just accumulate. We see a lot of people increasing numbers of falls in their homes where they can't get themselves back up, but they don't have anybody there with them. So I think that's kind of into this issue of, we're not really well set up to help support people with aging. And because this is public health, one of the tentacles then is we don't have the long-term care slots available either. And so where do people go as they age out of their homes? They don't have family who are able to take them. There's limited spaces there too. So certainly it's a more of a system problem. We also have some questions about the challenges of adult housing versus family housing, because when you add children in, then you've got other things to think about. And then many times families will have pets, and what do we do with those pets? So that's our next set of questions. So how do we promote a spectrum of supportive housing that can accommodate people in different phases of their lives? I've done my job really well when I got the panelists done.
Yeah, I guess the simplest answer to this is that we, and I think Beacon believes this, and probably my other panelists here would agree, like we need housing that fits everyone, and that we need a lot of types of housing to fit the wide variety of people and their needs. And that one thing we try to do with supportive housing is meet and create different types of supportive housing for different types of people that really meets different types of acuity needs and different types of families, individuals, youth. And so our family housing that we are trying to move forward tries to accommodate that with larger units, with more programming for kids, with kind of a wide array of services and such, playgrounds on the site and lots of things, educational support, and a partnership with the local school district around. So we try to do a lot of those things. I don't know about our pet policy, but I do think, like, as I said, that not a lot of this exists right now, and we're struggling to just create what we can. There's not enough service funding to create the supportive housing for families that we are creating. I'm trying to push a bill with the legislature that's probably not going to happen to get more service funding for family supportive housing, because there really is a real lack of state funding for this particular model. And to sustain a building with larger units, requires higher rents, which most programs, at the state level around supportive housing are really focused on individuals. And so it's a complex space, and to be able to really build it out just requires a lot more infrastructure and funding.
I think we also need to think out of the box. I'm a primary care doctor, so my solution to a lot of things, I have to just acknowledge, I think first about primary care, but I think we really need to think about how we as a culture treat people who are aging, and how we as families honor and consider our options as people are aging. And I just, on my social media feed this morning, was scrolling through as I had some coffee and saw in Singapore that they give financial incentives to young families to have multi-generational housing, to keep their parents or caregivers, and it has all these added benefits. And I don't think we think like that enough in this country, and it would be incredible if we could help incentivize or, give people a reduction in the cost of the construction to add a bar, or to renovate their bathroom, or to add accessible spaces so they could move their parent or great aunt or whoever it was into and around their family. That's not going to solve it all, but I do think we need to not think about sort of institutionalizing or public service solutions to all of this. It's really about culture shift on a lot of levels. and about shifting the strain we put on young working families to be able to recognize how a lot of these solutions could actually support each other if we thought about them differently or looked to other countries as to how we can incentivize this idea about collectively taking care of each other and making that more socially desirable and socially acceptable.
So I would just say quickly, we were actually talking about this during the break, is that, a lot of our supportive housing stock was created kind of based on this evidence base that was for, a pretty small segment of the population. And so this that, what works for everybody is, having an apartment with a case manager, your own apartment with a case manager who checks in on you maybe, once or twice a month. Like, that might not be the best model for everybody if you're used to living in an encampment or in a communal situation. It can be very isolating. And so I think there are different models that it's really tough to get any kind of housing built, I think, and then it's even tougher if it's like something that's kind of a little bit outside the box. But I do think that, yeah, there are many different people. There's a lot of variety in terms of people experiencing homelessness, and that I think we need to be listening to what they say they want in terms of the housing and services available, and then trying to design programs around those preferences.
So I'm hearing, and this is a similar discussion we have in disability services, is how do we recognize a person's dignity and their own say, having their own say, their own choices, their own decisions in how they receive services, what types of services they receive. I also overheard your discussions over the break on the harm reduction and risk reduction model. If you've got drug users and you put them in housing, your first task is not to address the drug use, it's to get them housed. And so you now have housing where drug use may be happening, and we're seeing community pushback on those kinds of things. I know in my work, we see sometimes community pushback on where group homes get located, where people with disabilities can live because they look different, they may live differently. And so we've got this whole perception issue and how that impacts things. I do want to quickly touch on the concept of encampments. So we don't want to see people living in encampments out in their tents and in these communities of encampments. We may not want them living in our neighborhoods, we won't want to build supportive, affordable housing in our neighborhoods. So where do we want people to live? So for each of you, what do you see, what would you most like the public to think about in terms of what we should be creating to help house people who are currently unhoused?
Yeah, I think this has been an extremely contentious and difficult issue in public health, and there's a lot of different perspectives about it. So I think, in Minneapolis, we over the last 5 years, we've really run the spectrum in terms of like, we had Powderhorn Park where we had, 300 people in tents, kind of in this like kind of semi-sanctioned encampment environment, 5 years ago. And now we're in a situation where, anybody with a tent, or that's kind of looking to sleep in an unsheltered situation now is kind of getting quickly told that they can't do that and kind of asked to move along. So, and it's a really difficult topic. I think that there are some aspects of, being in an encampment that, especially if you're, using, fentanyl or methamphetamines, that can be protective in terms of, people learn survival skills in terms of, having support around them and not, overdosing and having, being able to be served by harm reduction programs. And there are other aspects that are exploitative in terms of, trafficking and other things. So I think it's really requires kind of a nuance to it that I think is often lacking. And I think on the housing side of it, I think, housing is one component, but I don't think we can just say, we need to take everybody that's in encampments and move them into their own housing. And that should be the primary thing, because there are health effects of that I think we also need to be aware of in terms of, is that always the best thing for their own health? And then finally, I would just say, I think there has been a lot of work, particularly in Hennepin County, around talking to people in encampments and learning like what's the kind of housing that they would want to go into and would stay in. And so there's starting to be some programs, like for example, I think Boom Flats, but Claire Housing, that was programs that are now being designed around those preferences. And so looking at how effective those are and kind of scaling up those programs, I think will be an important component of it.
So at Beacon, yeah, we've been one of the forefronts of trying to build housing that does directly kind of work with folks moving out of encampments using the harm reduction model with service providers, where folks are directly being moved into housing and attempt to get services and kind of move them along. I would say that there's places it's been working very well. So an example is one of our newer buildings that's in downtown Minneapolis called Minnesota, which is a partnership with the Red Lake Indian Nation, is really creating a harm reduction model with services culturally specific for the native population, and is directly moving folks out of encampments and finding a lot of success in that model. I'd say in other places we've been doing kind of similar models, we found it to get overwhelmed with the community need far exceeding the ability of our services to really hold that in, and the amount of security and costs it creates to try to create a safe environment for folks is really difficult. And we found that in one of our places in St. Paul, and the amount of resources and places and the nuance that's needed to really care for folks in those spaces is difficult. And so I think learning about what are all the right models and public interventions for folks in these spaces, and when there's just a few of them out there that you're trying to put everybody into, it doesn't always work. And so really needing, I think, continuing more sophisticated approach around this. But unfortunately then, I think we're in one of the swings of public opinion that's anti that, right? That folks are more like, get these buildings out of here, don't let drug use happen in any buildings. And I think the kind of, NIMBY, not in my backyard pushback we get, we're seeing that more in creating new housing. It's much higher now, and in some of our current housing. And so I think that's a difficult space. Is the public reaction is to draw back when we're being overwhelmed by the community need, instead of lean into how do we create more, fund more, and find more ways to service the complex needs in our community.
I agree with a lot of what's been said, especially Josh's emphasis on really listening to people in these circumstances. I will only add very briefly that these are folks who, and will note that I've learned these lessons from some of the best street outreach nurses who work at Healthcare for the Homeless, who have spent months and months and months building trust, because the trust takes a lot of time. And these are folks who have been through horrific situations and often been really harmed by the systems we have that we think of as well-intentioned, and that really don't land that way for a lot of folks using drugs, and a lot of people experiencing homelessness who really get stigmatized and discriminated against for a whole variety of kind of intersectional reasons. And I think we have to trust that they know what they need. We need to really listen. We need to recognize that they know how to take care of each other, and are doing so in the best ways they know how. And it doesn't look like what I would think or want. It doesn't look tidy. It's maybe dynamic and nonlinear, because that healing and that trust building takes time. And I think we need to really open our minds and our hearts to what that might look like, and how we all can get there collectively, to recognize that's part of our obligation and part of our land acknowledgements and part of our commitments toward really facing the place we've ended up as a country and as a society. And leaning away from that is only continuing to perpetuate the problem, pushing it out, interrupting the relationships our outreach team can make with people, and often right as you're on the cusp of someone getting ready to try a medicine or get a referral or get treated, come into clinic for the first time in years or ever maybe, those encampments getting cleared only worsens the problem and interrupts those relationships. So it's a tense and complex situation, and we need to really partner with people to figure out how to do better.
Don't give up the mic yet, Dr. Kate. This is going to be directed at you first. So we're going to close with a speed round. In 60 seconds or less. If there was that one thing that you could choose that we're not measuring that we should be measuring to be able to help us collect data and understand this issue better, what would it be? Go.
I've been continually disappointed, as Josh knows, that we haven't committed to this homeless mortality report, toward really facing the impact of these choices on the lives of Minnesotans. So I would love to see us lean into that and lean into refining that and lean into advancing an understanding of how many years of quality of life are we losing by choosing to ignore these investments, and what are the impacts on infants who are brought home from the hospital into shelters, really taking a life course look at bravely measuring, not just to measure for measurement's sake. I'm not one of those kind of researchers. I'm a measure for the sake of holding ourselves accountable and pushing ahead and holding ourselves to the commitment that a lot of well-intentioned things have turned out really badly over time because they've been designed wrong or because other factors are at play, and we have to get brave enough to look at that and to kind of face up to some of those downstream impacts. And somewhere along the way, I think we should also measure whether people are able to access a trusted primary care clinic, because in national and international research, just being able to name who your trusted healthcare provider is reduces your risk of death.
Yes, all of that. And then also, I think I've been interested for a while in doing a deeper dive into the relationship between homelessness and, and Medicaid or in medical assistance in Minnesota. And, because we know that most people experiencing homelessness are at least income eligible for Medicaid, but we don't, I think, have a good sense, or at least I don't have a good sense of how many of those folks are, currently enrolled in a plan. And then if they're enrolled in a plan, are they getting preventative care? What are the health outcomes? So I think that's another area that we could be doing more with.
I think both of my colleagues here are more on the research and have a much better understanding of kind of the needed data points. And so I echo and support all that they would say. I'd say a lot of my work ends up on the political side about how do you sell this? How do you make the public and politicians support this? And I think much more research, right? So many of the interventions that we currently do are incredibly costly around, emergency rooms, around, shelters, around different things. And there's been some good research around how much we spend right now versus smarter approaches like supportive housing or the other interventions that we've talked about today. And so more data on that and then what kind of investment it would really take. I do think being visionary around this is helpful too. Like what investment would it take to end homelessness in Minnesota, and using smart interventions versus what we're doing now, and compare those numbers and talk about that with policymakers around their budgets, I think would be really powerful.
All right, well, you guys as panelists, you did great. Let's give them a round of applause. Before I turn it over to Lindsay to close us out, just a few thoughts. As I said at the beginning, on paper, this sounds like a simple issue. People are homeless or housing insecure because their income is in alignment with what their housing costs are. So all we need to do is figure out how to make that align, and we've got the problem solved. But as always, it's never that simple. So I think we've got three very good perspectives on this: policy-related, data-related, primary care-related, and we could have gone into much more depth. And so really appreciate your attention today. Thanks for being here. Thanks to MPHA for asking me to moderate this again today. And hopefully you've got some ideas to take home and think about further. And so maybe, in your own policy advocacy efforts, this is an issue that you might think about. So Lindsay, I'll turn it over to you.
Thank you. Thank you. All right, let's thank Ken for moderating today. Thank you, Ken. On behalf of the Policy Forum Committee, Angie, Kathy, and Leah, thank you for being here. This is our last forum of the year. We're talking about connecting the dots this forum series. So a reminder, we talked about food insecurity, we talked about mental health, and now we're talking about housing. So they all are so connected. And we hope we brought that to you today as our final workshop or our final forum. The back of your agenda, please turn there briefly. I'd like to thank all of the friends of the forum who help support this work and let these forums be possible. And I'd like to remind you of our annual conference, May 16th and 17th in Duluth. There's another week about to register. And June 2nd is our business meeting and awards ceremony. We're still accepting nominations for awards. Please nominate your colleagues. That's due Monday. And my final thing is a Starbucks gift card for the person who has the closest birthday to today. Anyone late April, early May? Anyone May at all? Anyone April at all? Anyone end of March or early June?
There we go.
Yay! Starbucks winner! All right, thank you all. Nice to see you today. That's a wrap. Yay! All right, thank you, Ken. That was wonderful.